just start off that thank you, Xray, for inviting me here to talk. And I'm happy to be in Athens to partake in, I guess, your guys' first National Congress of Medical Physics. So, again, I'm from Lugano, Switzerland. I'll be talking to you guys about the Radixact system, and specifically I'm going to be talking to you about the most modern modifications, what I like to call 3.0, which is really the newest of all the softwares in the platform. And so when we talk about treatment adaption, I kind of just put together this little schematic, and really what is treatment adaption? There's a lot of variants, but I'll say is, you know, the radiation therapy process is pretty linear. You know, you take an image, we calculate on that image, we verify in the IGRT process that image, the setup, and now I put in a little, now we can evaluate. I mean, this is the big step that all the technologies, various corporations are working on, is some sort of evaluation, whether that's in real time, whether that's offline, but then, okay, we make an evaluation, can we treat, go further, or do we somehow get off this, deviate from this linearity? Before I go on, I'll disclose that I am receiving an honorarium to give this talk, and these are my views. So, adaptive radiotherapy. So, I don't know, maybe many of you guys have actually already read this article. I think this is a nice summary article. Anyway, I just thought I'd throw it up here. And it really talks about, this is from a couple years ago, and it talks about the state of the art, let's say, of all the various technologies and how they're working on and various workflows that we're working on. But there's a lot of workflows. But I wanted to use actually their schematic here on the right side, the figure you're going to see. So we're going to use this because I think it's pretty good. And so when we talk about adaptive radiotherapy, usually there's three workflows. There's this offline process, there's an online process, and there's a real time. And you can see them delineated here, or maybe not so much on the screen here, but there's three processes there. In the offline, really the idea of the offline in general, what they say is it's about slow systematic changes, deviations from the baseline, which means the calculation on the CT sim, the KVCT, some sort of online adaption because you have a non-systematic change in the day which does not correlate to the baseline, or you expect there to be changes from the baseline, which is usually due to some sort of movement, so respiratory movement, peristaltic movement, and you take that into account. I'm not going to be talking about the last one there, the real-time adaption. Tomotherapy does have this, or Radixact has this capabilities, that's called synchrony, where they actually move with the target motion, but I'm going to be talking to you instead about these other two here, okay, offline and online. Specifically, I'm going to talk to you guys is really on the newest platform, where do these 4 points play in? And this is going to be the KVCT imaging, which they call ClearRT. There's the new optimizer, which is called Volo Ultra. And then they have two modules, which they call Precise RT, which is their treatment adaption module, and then there's retreatment Precise RTX. The first 2 points I'm really going to glide over. I mean, really all these could be presentations, and in 20 minutes there's not much you can say, but we're going to glide over the first two, and the last two will get a little bit more in depth. So I promised I would talk very little about the first two, and really that's what I'm going to do. I'm going to let you guys look, I guess, at the images. So ClearRT is very high quality KVCT, and I think that if you guys want to know more in depth, what I would tell everybody is I'm going to put two papers up here, and you guys can read the papers. And the people that are much smarter than me in imaging world who have tested this in and out, and you can really get numbers and understand how they compare to diagnostic and other available imaging on treatment machines. This paper right here was published a little less than a year ago by Wolfgang Thomé and his group in the Bronx in New York City, which is a nice paper. And likewise, this just came out a couple months ago, and this is a very in-depth testing done by the University of Wisconsin. I think the only things that are really nice to point out here, you can kind of see what the imaging people are used to on the MVCT, and this is low contrast visibility, and then you can see what the KVCT is, and it's in line with a diagnostic scanner. And I'd say it's very good KVCT, and so you guys can take the look as the images as we're going through this talk. Volo Ultra is the new optimizer, which was a surprise to me when we got it actually about 6 months ago. I'm not a guru, and I'm not an expert in any means on cost-benefit functions and algorithms. But what I can tell you is that it's called a memory limited Quasi-Dun algorithm. I gave the paper if people want to read a little bit more about it. It's unbelievably fast. I mean, this is shockingly fast, and there's some freedom to it, and so you can change certain parameters that allow you to work on this convergence and how fast it is, but I will say is it's a set number of iterations. you set these parameters, you click the button, and depending on how you've set up your parameters, it has a full convergence within 2 to 5 minutes. And I would say it's closer to 2 than 5. It really depends if you're efficient in your parameters. Tomotherapy has worked a great deal on this optimizer, so it's very different from the precedent. And so you can actually, this is probably because of this, their knowledge inside the CyberKnife world. They've now brought in that you can actually take in dose gradients into it, so it's called a normal tissue objective. A very nice key point is they've actually taken into account Mlc characteristics. So anybody who's worked on the tomotherapy machine knows that the Mlc, which is slowly coming out, even the new AAPM task group on tomotherapy really dives into the Mlc. It tends to be maybe the weakest link, and now you can actually take that into planning, and so you can actually speed up plans this way. You can also guarantee a higher quality of treatment plan. Likewise, there's now the capability to take into treatment acceleration, so you're making faster treatments, and like I said, you can actually accelerate the optimization. For those of you who are familiar with the actual the user interface, it's very similar. Now you just press this button, it does its set number of iterations, which the default with their default parameters is about 60 iterations. And then you define your parameters. You can pull in whether it's a script you want, and inside the script, one of the nice things that they now have, if anybody has experience with the IDMS system, but now you can have all the dose volume constraints just built right in, and you can get them checked off. So the big key to this really was Accuray in this new platform about 6 months ago, 8 months ago in our clinic when we had this installed, gave us the ability really to have really high-end KVCT, low contrast, imaging, very fast. It takes about 20 seconds to 60 seconds depending on the length of the KVCT that you're scanning, and then all of a sudden very fast calculation, which was unexpected. And so where does this come into account? And this comes into account in adaption and adaptive planning. And so we get to this module, which is called Precise RT. And really, the way that tomotherapy had originally done this, again, was more so of a dosimetric view, that you're going to be following the patient dosimetrically. And so patients are enrolled initially. So as soon as your doctors are approving of the treatment plan, you can enroll the patient immediately, then choose, and it's enrolled. And then you can choose protocols. You can actually set protocols inside the enrollment. Otherwise, at any point during the treatment time, you can go back and enroll the patient in these protocols, as we'll see. Then really you can set everything in there regarding what you're wanting to follow for that patient. And what this really does then is automatically every day after you've taken your daily image, that's being sent over and automatically deformed. You have your KVCT from the CT sim, which is being deformed to your daily KVCT, the clear RT, and then you're having a new dose calculation being performed on that KVCT. Then you have the report generation that's coming out, depending on the report or protocolization that you've decided upon. And likewise, this is based off of what I was going to say is the MIM architecture behind the scenes. And so anybody who knows MIM is it's very strong. There's a lot to do it. They've streamlined it in this upgrade. So there's been a lot less options. It's not as confusing. It was quite robust and strong, but also confusing. But you can still look very cleanly and easily at the accumulated dose. So all the dose that's been accumulated to that point, evaluate the organs at risk, the BTV coverage. Likewise, you can do the summation and then do a projection of that last fraction all the way to the end if you want to see if the patient has, what they have received and what they're going to receive if we don't make any sort of intervention. And so all this really is giving you a lot more flexibility and power, I would say, inside your clinical judgments. So what does this look like? We click on the button, and what you open is now the MIM Vista, or I guess it's MIM now screen. You can see your list of patients that you've enrolled. You click on the patient, you get all the days. You can see really quick if you like colors, did I fulfill all my check boxes? And you can see on ours, everything's no, because I'm not somebody who really fills out or for that matter, I will say is I had never protocolized. What we actually use then are the dose volume constraints, which is an option as well. So we have very set protocolizations inside our center about how we accept plans in the planning. However, then I just keep those, and those just repeatedly go throughout the day. And so I can kind of see, what we really use this is inside our IGRT check. And so weekly, we look at how our patients are doing throughout, and if we have issues that are going on, whether it be in setup or because we've been called to the machine, let's say, because we're seeing differences inside the anatomy, we'll open this up and kind of see how they're doing. So again, you can click on that report, then you can actually see a lot more of the report if you want a little bit more in depth. Again, there's the user-defined report, so if you really wanted to have different dose volume criteria rather than the ones that are used in the acceptance of your patient, it's all there. Or, as I said, is you can just take almost like a default like we do. Well, if that's not enough, it's really simple. You click on that fraction and it opens up. You can look at, so it can give you anything from differences, let's say, between the two. It's very hard to see on the screen here, but here is the planning KVCT. You can actually see the KVCT, which is taken at the machine, which has now been deformed onto the, or I should say, put into the registration with the KVCT from the CT sim. So they're one or the other. You can look at the dose. You can investigate the dose. Here I could see that there was a change inside the bladder. So now I'm taking this and I'm looking at it. If I wanted to, you can get into it. And this is going to be really hard to see here. But anyway, I wanted to look in and see where there's a little bit of underdosage of the CTV, understand what it's due to. So this is really powerful. You can really look into whatever you're seeing there on the patients and their daily setups. So Precise RTX is a retreatment module. This is how it was built, and this is why it was built. This was a sour point, I'll say, on the old treatment planning system of tomotherapy, that they couldn't really interact or communicate with the outside world. Well, this has been changed since the IDMS times, and so what they built it as for is almost like a port. So you're coming in, whether it's from Eclipse or Monaco or some other system that you're using, you're able to import all the doses in the CTs and whatnot, whether just a DICOM export or the portal access, let's say, from the old tomotherapy world. This gets you back into this MIM where you have all the ability to deform dose, deform structures, and do a lot of summations. But that's not what I'm going to use here. What we use it for, and what I'm talking to you today about in Adaption, is we use it specifically for the fast contour propagation. So this is a very fast contour propagation that's automatically done. And so what we're able to do is open up the clear RT instantaneously. So at the operating station, our therapists do a KVCT. We immediately, as that's finished in 20, 40 seconds, the patient's on the table, I can open this up and have new contours propagated onto that daily CT within 2 minutes. And then it's up to you to take a look at it, make sure that they're okay, is the doctor okay with everything going on. And what I wanted, maybe I'm not hitting on the points, but this is really the reason that this is working so well, is because the clear RT is such good at KVCT imaging. These algorithms behind the scenes are very powerful. They're able to do very good deformation, and therefore it's carrying over the contours very well and very quickly. And so now it's actually on us, and a lot of it is to understand, is this okay? Are these contours okay? Can we go along with this? And so I just wanted to show you guys a couple quick examples that we're seeing in the clinic. And so this was a very young 26-year-old patient that we had now, actually probably 4 or 5 months ago, with a really aggressive breast cancer, and including all her intermammaries and an intra-aortic, you can't see it there, lymph node, and it was a very complex plan, very pushed plan. And she had a huge seroma, post-surgical seroma. The decision was made to treat her anyway, given to the aggressivity and her age. They wanted to go forward with it, even though we know that these patients then to have reabsorption, and so we were going to have changes in the anatomy. And so, as you can see at the machine here, we ended up seeing this, pretty quickly, that after a couple weeks she started reabsorbing. So we intervened, and we went through this adaption process a couple times with her. But what I really wanted to show you is these are the automatically deformed contours, which then, in this case, our doctors decided not to touch. They were so pleased with the cavity being recontoured and all the other organs. I mean, really, sometimes this is shockingly good at its deformations, especially in the thoracic area, which is not an area that you would expect to be adapting to, which we've unexpectedly been intervening on quite a lot. Throughout these last months, I've started just playing around and looking at different areas and seeing how well these contour propagation and the deformation algorithms are working. This was just a test looking at head and neck. At the head and neck, I think you guys can see it. Not only is it a really good image, but it does a really good job at the contouring. You can see here actually on the clear RT, there's a little bit of photon starvation. You see that around. We could maybe do a little bit better by selecting. You can actually do quite a lot of manipulation of the CT protocols, which we don't. But does an adequate job, good job. And the last clinical example that I'm going to get into is more of, obviously, when you're talking about adaption, you're usually talking about, as for instance, the last presenter showed, maybe gynecological, but abdominal pelvic region, where you're doing this in combination with SBRT or anyways with large hypofractionation. This is just a clinical example of what we, what we see, and I'm sure that a lot of centers see, but now we can take into account. But this is a standard prostate patient. What I wanted to show you is, if you look, you can see a couple calcifications. Patient comes in, and it was probably after his 5th treatment, but comes in and has a large ball of air in his rectum. Not uncommon. This was a very large amount of air. But what was really interesting is I've never seen a prostate move this much. This prostate moved almost a full 1.5 centimeters. I mean, that's huge. And then it sat right there, okay? So yeah, we got to do something. We call our nurse, I think like most people will have inside there. And this doesn't work. Call down the doctor, call in the nurse. Nurse comes, puts in a catheter, removes the air, and then it gets really interesting. In this patient, which I had never seen before, usually you have anatomy that turns somewhat to its original spot. In this patient, it didn't. We actually had a patient, and we found out after this, who had intestinal surgery, and so probably things were a little bit more mobile. And so you have a drastic change inside the situation of the rectum. The rectum actually was sitting inside, like almost wholly inside the PTV. And so this is just a simple, maybe an extreme example, but of a lot of what you're going to be seeing, right? Or what we see inside the clinic all the time. But what do we do with this? Historically, you ask the patients to take a walk, empty their bladder, remove the gas. You reposition, re-image, you hope that things are a little bit better. Maybe you get the thumbs up or thumbs down, or you give no treatment. Let's see how it is the next day. Or you decide to replan these patients problematic, because there tends to be maybe 1 out of 8 patients which are problematic with a larger PTV margin. Or you treat with some sort of treatment adaption. And so this has really become possible in a quick process on the new Radixact system. And so what I wanted to show you here is, right now there is no clinical product to buy, which they're actually working on, and I know going to be releasing slightly soon, but Xray doesn't. This is not a treatment online adaptive product. This is something that's being worked by Xray, but what we've developed is, let's say, all the tools are within the TPS right now to have that workflow. And so what we do is we acquire the image, we use what I was just talking about inside our process, taking that image, having an automatic contour propagation, saving these, having these, reopening them. We import, let's say, the optimization script for these patients, and then we have this quick new completely optimized plans from the Vola Ultra. And this whole process takes about 7 to 15 minutes. And I would say and a lot of this has to do with how many contours you're propagating. So if you're in a head and neck region, it's probably on closer to the 15 minutes. And I would say it's 7 minutes on the prostate. What I've noticed is most of the corrections, when you really have to put your hand in there and correct, and the doctors have to correct, it's usually around it's in the soft contrast issues. And so for us, that's in the prostate region, the bladder to prostate versus rectum to prostate area. But again, these are quick. You're only making slight changes right around there. But without contour adjustment, from when you're taking the image to when you're retreating the patient, is very fast. Really, the rest is dependent upon the organization of the clinic, and that's what I wanted to get to. And so, I'm being general here. 15 minutes. My guess is it's way less than that on some, and maybe a little bit more on others. But this is the first thing, and this is actually why when I initially put together this talk a little differently, I did this for Xray internally, because nobody was really selling this machine as an adaptive machine, but that's what this machine is. It's really, they've put all the effort into making this very quick. So online adaptive, is this it? Is this the online adaptive for Radixact? The answer is well, in my opinion, now that we've been using this for 8 months, it's all about your clinic. Do you guys have the resources in the organization? Because there's a lot of resources in organization, but the tools are here to do it very quickly. From my experience, what I thought was really interesting is it's so fast and so well done on this system, actually, that it's actually, you can integrate it how you want. So a lot of these for us we evaluate the patient, we see we need a modification, but at the same time we're not too worried, we're not doing SBRT, fractions, and so we have the patient step down, maybe we do everything, call the patient back up in 20, 30 minutes, we treat a couple patients in the meantime, and that works for us. We don't have all the intensity, let's say, of the need for the medical doctors to be going over, re-examining every slice of the PTV. Also, we've been using this interestingly for even non-standard, because it's become so easy, is what you tend to see is patients are more tense inside their CT sim. So there's a lot of tension. They relax on the treatment bed. You see this, right, in the whole pelvic area. You also see this for breast patients, often around the arms. Surface guidance could help here. We don't have that yet. But likewise, this is very useful. So once this happens after maybe a week of treatments, you kind of see this in the patients. You can actually re-perform a plan on that patient. So more so our issues now are administrative. How do we document, standardize the nomenclature with so many adaptions that are going on? So in conclusion, I guess I just wanted to show you guys, to me, this has always been the tour de force of the tomotherapy, and now I'll say the Radixact system is its ease of workflow. It's a very well thought out workflow, but now this platform has really become powerful. You have fast imaging, you have high quality imaging, you have the ability to do really quick optimizations, and really what this has become is an adaptive machine. And so that's all I wanted to talk to you guys about today. And if you can see that, this was last week's hike. So.
Thank you, Nathan, for your nice presentation. We have time for one or two questions. Are there any from the audience? So I have one question. If you want. So the KVCT was very good. So it is a cone beam or a fan beam CT? Because
it's in between. It's in between. So you can choose. I will say is. You can choose. It's let's say the package of reconstruction on the flat detector, and at the same time you can actually choose the size of the field width of the actual beam itself. But the smallest it is 5 centimeters. So it's not a full KV. It's kind of an in between there. But it is helical KVCT, but it's an in between.
Okay.